So these are last year's cancer data, and it's interesting to know that cancer is the leading cause of death from people between 40 and 79. Afterwards, then heart disease and other problems become more important. I will only focus here on some of, but the most frequent of the gynecologic cancer. Anyway, about 91,000 of new patients every year, and 28,000 deaths every year. So compared, of course, to other cancers, the numbers are smaller, but the mortality rate or the death rate is significant. Look here, we have about over 200,000 of patients with breast cancer, but only 39,000 deaths, because most of these cancers are diagnosed early, and then with the early diagnosis, the survival are better. So why do we get cancer? Unfortunately, this is a very, very difficult question. People have been working on it for decades, and we still don't have a good answer. Because there is not just one cancer. Every cancer has a different background, has a different history, different risk factors. And the development of cancer is usually not one thing, like in an infection. A bacterium grows, you get a bladder infection. The development of cancer is a development which takes many different steps, where cells get more and more abnormal, and where, of course, on the other hand, also our immune system has plenty of opportunity to kill those cells off, because we all develop abnormal cells in our body every day. Risk factors for cancer in general are a variety. Number one, infection. The most known infection is the human papillomavirus infection, which increases the risk of cancer of the cervix, but also increases the risk of cancer of the anus and cancer of the throat. About 25% of head and neck cancers are related to this infection. There are other infections like hepatitis infection, increase the risk of cancer of the liver. Lifestyle factors, of course, we all know about smoking, but we are learning more and more about the importance of fatty tissue in the development of cancer. So the importance of being overweight will increase the risk of many different cancers. We'll talk quite a bit about this when we talk about uterine cancer. And will also decrease a little bit the effect of cancer treatment. So that is going to, obesity, some people say that in the next decade or so, obesity is going to overtake smoking as the most important lifestyle risk for cancer development. Dietary factors play a role. Occupational risk factors are not that important anymore, but in the past you've heard about the asbestos causing cancers of the lungs or even the peritoneum. And the further distant past, chimney sweeps had a higher risk of cancer because they were in contact with all those carcinogens. There's a lot of talk about, a lot of importance in hereditary cancer, which overall are rare. Only about 10% or less of cancers are developed on a hereditary basis. But of course, for people who have these syndromes, the risk of cancer is very high. And we're going to talk some more about that when we talk about ovarian cancer. And of course, women-specific hormonal factors play a very important role in the development of cancer. So the gentlemen in the room don't have to worry that much. The risk of the influence of testosterone on prostate cancer is minor. So the hormones are mainly important for female cancers. Cancer prevention, of course, prevention is the best treatment. But prevention, very effective prevention, means that we need to know exactly where the cancer is coming from, number one, and we need these factors. We need to be able to modify them. If we have a genetic mutation, there's nothing we can do about it. We cannot modify that. I want to talk just a little bit about the studies we are doing to investigate these questions, because very often you hear in the news a study so-and-so reported that and that. There was, for instance, a couple of weeks ago on NPR, I heard a study says that women do not need regular pelvic exams, because it's not a good technique to diagnose ovarian cancer. Studies like that come out, but you need to look at them critically. Not everything which is published in a study is worthwhile or is just a recommendation. So, with these studies, what we mainly link observational studies. So that means we just look at all patients with ovarian cancer and see what happens. Then there are cohort studies where we follow patients over years and years and years. We assess risk factors when they start the study, and then we follow them and see what happens. One of the biggest studies is the nurses' health study. So they interviewed nurses because they felt they would have more or less similar access to health care regarding risk factors, and then followed them over decades to see, and then could look back, why did this person get this cancer or that cancer, and so on and so on. And we have learned a whole lot from these studies. The other thing is the Framingham study, where they looked at the people living in Framingham and seeing what are risks for heart disease, and so on and so forth. A different study approach is a case control study. So where you interview patients, the cases who have a specific cancer, and then you ask the same kind of questions, patients of similar age who do not have the cancer, and to see if there is any questions, any difference between those patients regarding their genetic background, their eating habits, their activity level, and so on and so forth. And then there is something called a meta-analysis, where you bunch together several studies trying to answer the same question, so that you then get very large numbers. And sometimes these can confirm previous results. But of course, all these studies have problems. The information may be incomplete. So someone, let's say, has colon cancer, remembers more what their bowel function was like than someone who does not. There also can be bias introduced, that the result is related to something else, and not really the factor we are looking at. For instance, people who have less physical activity tend to be bigger. That just goes together, and sometimes it's impossible even to divide that. And then patient number is a big issue. Number one, it can be too few. So then you don't get an adequate result, or a result with statistical significance. Now, sometimes I think there also can be too many. So if you look at 10,000 patients and look at factors, you will find statistically significant differences, but they may not be important. So for instance, if you eat a lot of yogurt, that increases your risk of ovarian cancer. But if you need 5,000 women to figure that out, what does that mean for you as an individual? I still eat yogurt. So again, all these studies need to be all taken with a grain of salt, and never read one study and say, okay, this is how it is. The best way really is the randomized clinical trial. And even there, the experts have discussion about it. But a randomized clinical trial is if you have a group of people and by luck, someone gets treatment A and the other one gets treatment B. That's how we learn how most of the drugs work. That's also what we learn a lot when we talk about hormones in cancers, what effects hormones have. But those are the studies which really give you the most accurate results. But on the other hand, they're also very, very expensive. Because you need to spend a lot of time informing patients, educating patients about the studies. You need to give them the different medication. You need to follow up for years and years. These are very, very expensive studies, but this is really the gold standard as far as getting some knowledge about cancers and risk factors and treatment. So let's talk about a gynecologic cancer. And here we're talking about the main diagnosis, uterus and ovarian and fallopian tube. Since we have regular pap smears and treat all these precancerous lesions, we only see about 10,000 or 12,000 women with cervical cancer in a year in the United States. So this is just a very big success story regarding screening. Worldwide, it's after breast cancer still the most frequent female cancer. So here, to review the anatomy, this is the ovary. These are the fallopian tubes. There's a fimbria. They carry the egg to the sperm, which gets fertilized somewhere here and then works its way to the uterus. The uterus has a muscle on the outside, the myometrium, and then the endometrium. That's the glandular tissue and the inside. So this glandular tissue causes the most gynecologic cancers. And then this tissue here, and we thought it was just the ovary, but I think I should paint the fallopian tube as well, because we're learning more and more about the importance of the fallopian tube. Endometrial cancer, about 40,000 women a year get it. The most frequent type, and the one we're going to be focusing on, is the type 1 endometrial cancer. That is the hormone-related uterine cancer. It comes from the lining of the tissue inside. It is usually diagnosed at an early stage, and it usually can be treated quite well with surgery. Sometimes we also give radiation and rarely chemotherapy. There is also a type 2 endometrial cancer, which has a completely different background, completely different steps lead to it, not hormone related, and which tend to be much more aggressive and spread to other areas. And rarely there are malignancies from the wall of the uterus. Those are sarcomas, but they're quite rare. You probably heard more about them now when we talk about morcellation, cutting up a fibroid in little pieces. That has been through the press recently. So the whole story you can bring back regarding prevention and also sometimes treatment and risk factors. You can bring back to two factors. The lining of the uterus, the endometrium, grows with estrogen. Estrogen is the hormone which is produced in the first half of the menstrual cycle from the ovary. And then after an egg is released in the middle of the cycle, then corpus luteum forms, and that produces progesterone. Progesterone is the hormone of the second part of the menstrual cycle, and its function is to prepare the endometrium for pregnancy, and if there is no pregnancy, to change it around so it is shed as a period. So always keep in mind, and with that you can understand the rest of the lecture on uterine cancer. Endometrium makes it grow, estrogen makes it grow, progesterone makes it get smaller and makes it have a period. We know quite well the clinical signs of development of endometrial cancer, although we do not know the specific events at the cell. We know that estrogen increases first the thickness of the endometrium, so makes it more lush, makes it thicker. Then the next step, it causes hyperplasia and complex hyperplasia where there are more glands around. So the glands are closer together. There's less intervening tissue. And then these glands cells in the glands look kind of abnormal, atypical. And then there are several more steps. We start to know that P10 plays a role and a lot of other factors until a type 1, usually well-differentiated endometrial cancer develops. And this is what it looks like. So you see here, this is what the normal endometrial tissue looks like. See, you have a lot of tissue and some little glands. Those are glands. And on hyperplasia, you see here, you have more glands per tissue area than here. And if you take this a step further, you get to a cancer where you have just glands and very little tissue in between. And you see here, this is a cancer which just has not grown into the wall of the uterus. It's just confined to the endometrium. So that gives you a picture. But what happens at each step, we really do not know for sure. So risk factors: too much estrogen, too little progesterone. So how can you get that? Well, long time between periods. So for women who still have their cycle, some have periods only once a year or every 6 months. Initially one thought, well, that's kind of nice, then don't have to worry about it. But you do have to worry about it because it gives your body a lot of estrogen but very little progesterone, and that way increases the risk of cancer. Or some people don't have periods at all for a variety of medical conditions, and again that increases the risk of cancer. Women who start periods early or go through menopause late usually have a higher risk of cancer. And very important, being overweight, because the fatty tissue produces extra estrogen. Then you can take the estrogen from the outside. So estrogen-only medication. As a matter of fact, when we started to use so-called hormone replacement therapy to treat hot flashes and a lot of other things after the change of life, initially women received only estrogen. And one could see that the incidence of uterine cancer went up, until we finally figured out, we need to give it together with the progesterone, and then the risk came down again. Another drug which is often used is the tamoxifen. Tamoxifen is used for the treatment of breast cancer and also for the prevention of breast cancer. But it works for the uterus as an estrogen, so it increases growth of the endometrium and increases the risk of polyp and slightly increases even the risk of cancer of the uterus. Now, having said that, we never ever recommend stopping the estrogen for breast cancer survivors because of fear of uterine cancer. Because the benefit against the breast cancer is so much higher than the increased risk of uterine cancer. But still, it's something which confirms the fact that anything increases the estrogen effect in the uterus increases the risk of cancer. A few slides of obesity. We think that this is the main cause for about 40% of the type 1 endometrial cancer. So that's around 20,000 women a year. And it's not just being obese. There's some altered steroid pathways, how hormones are broken down or one hormone transformed to another hormone. We also learn more about the insulin and its effect on cell growth. There is a so-called insulin-like growth factor, which is elevated in these patients, which increases cell growth, and that way increases the risk of cancer. And it's not just uterine cancer, it's also breast cancer and other malignancies. And experience have shown that the apples have the biggest problem. So those are people who are mainly big in the waist, in contrast to the pears where everything sits in the upper thighs. So especially for apples, it's very important to keep a normal weight because it's a so-called metabolic syndrome which has, and it's not just because these people are eating too much. I mean, there's something different about the metabolism, but it is very important that the weight is kept normal. And there's also now studies coming out that acrylamide, that is a possible carcinogen, and that is usually contained in white bread or carbohydrates. So this is the metabolic syndrome. And see here, they talk about breast cancer, and it's the same for uterine cancer. It's associated with diabetes. It causes more insulin. It causes the insulin-like growth factor and more cell proliferation. It affects also the sex hormone binding globulin, so this affects the hormone levels in the blood, which then can be metabolized into estrogen afterwards. And that is also after the change of life, because we're still, the adrenal glands and also the ovary produce even some low levels of testosterone after the change of life, and they can be converted into estrogen. With young people, it's the polycystic ovarian syndrome. What there happens is that multiple cyst follicles develop in the ovary, but they don't pop. So that means that the ovaries get enlarged with multiple cysts. And because they don't release an egg, they don't have the progesterone. So those are young ladies who have irregular cycles. Oftentimes, they also have insulin resistance, so they tend to be overweight. Infertility is a big problem because, well, if you don't release an egg, you can't get pregnant. And those are the patients where uterine cancer, endometrial cancer, is diagnosed while they're getting their infertility workup. And those are patients we also treat with metformin, which is a drug which is usually given for diabetics. But the metformin has an impact on this metabolism here, thus decreasing the insulin-like growth factor. As a matter of fact, we are using it now as a drug to treat uterine cancer. So that just shows you that how important these factors are. And of course, it's very distressing when a woman in her 30s has endometrial cancer and she hasn't been pregnant yet. Now, there are things one can do about that as well. But of course, here the best thing would be to prevent it in the first place. There are also some genetic risk factors for uterine cancer, mainly the Lynch syndrome, which includes a higher risk of colon polyps and a higher risk of colon cancer. So a very high risk of colon cancer, but also increases the risk of uterine cancer and increases the risk of other cancers in the gastrointestinal tract, and it also slightly increases the risk of ovarian cancer. And that is something which can be studied very well looking at some tissue tests. For instance, all patients who are diagnosed of endometrial cancer under age 50 are undergoing a specific test to determine if they are at increased risk for these genetic changes. Cowden syndrome is very rare. It's just one of the growth factors which is abnormal. And of course, there are many other factors still under investigation. You know, we're looking at parts of the genome. There are a lot of different factors which can increase the risk of cancer. Once we learn more about the Human Genome Project, you know, we may be able to do a genetic analysis and then at the end tell you your risk of this cancer is that, and that cancer is this, and so on and so forth. Now, I don't know if you always would want to know. But right now, you don't have to worry about it because we don't have it yet. So, and it will still take quite a while, I think, until we are that far. So, remember, to prevent then uterine cancer is just go the other way around. Whatever decreases estrogen and whatever increases progesterone decreases your risk of endometrial cancer. So, decrease estrogen, normal weight, you know, is a big deal. Decrease intake of those carbohydrates, increase physical activity. Smoking, yes, smoking decreases the risk of endometrial cancer, also because of influence in the hormonal metabolism, but I'm not recommending it, okay? So, but again, it shows, you know, how many different influences there are into cancer development. And of course, you should not take just estrogen replacement therapy, but your doctor should not do that unless they're very specific situation. Well, the other way around is increase the progesterone. Now, one way is, like with ovarian, you can remain pregnant all the time, because during pregnancy, you have a whole lot of progesterone around. The easier way for most people is to take birth control pills. As far as the gynecologic oncologist is concerned, everyone should be on birth control pills unless they want to get pregnant, because it reduces the risk of uterine cancer to by about 40%. Because birth control pills and most of the newer combination one always have progesterone in it. Now, there are also ones where you only have a period every 3 months or so, the seasonal and things like that. And again, they don't increase the risk because people get the progesterone on a regular basis. But I think it's also important to make sure you have regular cycles. You know, if you don't have a period for half a year or so, you know, it should be investigated. And you don't necessarily have to have any treatment, but you should take some progesterone to kind of make the endometrium shed. You know, it's this old wives' tale, you need to have a period to clean yourself. I always thought that was kind of stupid, but it's not. You know, so old wives' tale have a lot of truth into them, probably with experience, you know, over years and years and years. And of course, nowadays, we use the hormone replacement therapy only with the progesterone, either for more than 10 days or continuous. And again, all these medications decrease the risk of endometrial cancer. But of course, it's only a risk. You still, even if you do everything right, have taken birth control all your life, have normal weight, are in the gym every day, you may still get it. There is some data that perhaps taking phytoestrogen may help decrease the risk. So those are all the soy products, the black cohosh and things like that. We still need to learn a whole lot about that. The same thing with the omega-3 fatty acids, so that would be the salmon, which has a lot of beneficial effect for heart disease and things like that too. But again, these data, again, are one of those studies. Remember I talked to you before, cohort studies, where it's hard to get a really definite effect judgment. Now, for some people with the genetic risk factors, well, taking out the uterus, that solves the problem. However, for patients at adequate risk, just taking out the uterus to prevent endometrial cancer is not recommended at all. Because if you will do that with anyone, the risk of surgery would so much outweigh the risk of uterine cancer, because it's not, number one, the risk is not that high, and number two, treatment options are usually very effective. Now, important though is the evaluation and treatment of early changes. So again, being in sync with your body. If there's any irregular bleeding, spotting, discharge, or very heavy period, or any kind of bleeding, spotting, brownish discharge after the change of life, that should be evaluated. And then what we do is an ultrasound. We sometimes do a biopsy, and there are hormone treatments, progesterone treatments available for these changes to prevent a cancer to develop in the first place. Ovarian cancer. Now, that's the most feared gynecologic malignancy because it's usually diagnosed at an advanced stage, and with any diagnosis at an advanced stage, the outcome is not as great. We need to keep in mind, though, ovarian cancer is a conglomerate of many different things. Most are epithelial, but meaning from the lining of the ovary. But again, we are learning more and more that there are differences between what we call high-grade and low-grade ovarian cancer, that there are different mechanisms leading to cancer development, different risk factors, and so on and so forth. And there are also tumors from other parts of the ovary, from the germ cells and the stroma. So whenever in your family there is a history of ovarian cancer, you want to know exactly what type of ovarian cancer it is. So picture, I always say, picture of Aunt Lucy. You also need to keep the pathology report of Aunt Lucy, because that is very important for risk assessment. And see, this is how different this can look. This is the most frequent cancer, but this is a lower grade ovarian cancer. This is a mucinous cancer. So they can look very, very different. And you can imagine that tumors looking that different may also have a different pathogenesis, a different way how they develop into a cancer. Although it is the most deadly disease, screening for the general population is not recommended because it's rare. It's only about 1.7% risk of developing an ovarian cancer in the general population, and we do not have good screening tests. So then we would do a ton of surgery on patients who do not have ovarian cancer to find a patient finally with ovarian cancer. Initial studies had 50 surgeries for one patient with ovarian cancer, and a lot of bad things can happen with 50 surgeries. So risk factors for ovarian cancer is mainly ovulation. So when a little follicle pops to let the egg come out, it causes an injury in the lining of the ovary. And where there's an injury, repair needs to take place, new cell growth. And that is always then prone to be a little bit abnormal from all sorts of different factors, local hormones, or infections, and so on and so forth. And what we are learning more and more now is that the fallopian tube may be important. So the fallopian tube is like a little, it's very soft, and it lays over the ovary to pick up the egg. So sometimes a little piece of the epithelium from the fallopian tube gets stuck in the ovary. And we now think that this is a very important focus for the development of ovarian cancer. And we have learned that from patients with a genetic increased risk for ovarian cancer, where we remove tubes and ovaries just for safety. And we found that if we find very early cancer in these patients, it's mostly in the fallopian tube and not in the ovary. And that we were not able to make this distinction before, because most of these cancers are diagnosed at an advanced stage. And then, they're cancer all over the place, and you don't know exactly where it's coming from. Other factors, chronic inflammation may pay a risk. So people who take aspirin on a regular basis have a little bit of a lower risk of ovarian cancer. Chronic inflammation, chronic tissue irritation is a risk factor for cancer in all sorts of different areas. We also feel that, although it's still quite rare, endometriosis, that is endometrial tissue outside the uterus, in the pelvis or on the ovary, which sometimes can cause a lot of pain, may also slightly increase the risk of an endometrioid ovarian cancer. Regarding hormone replacement therapy, again, there are big studies showing a slight increase if estrogen is taken after the change of life. The old literature always said talc powder increases the risk. The data is really not that strong. But of course, if you put powder on the outside, it can possibly travel through the vagina, the uterus, into the fallopian tube. Nutritional factors may play a role, more saturated fat, lactose, that was the yogurt thingy. We do know that people in the northern hemisphere have a higher risk. I don't know, perhaps they eat more seal fat or things like that. But again, it must be some nutritional factor, but again, we don't have any definite knowledge. And of course, inheritance. Only about 10% of the patients with ovarian cancer have it on an inherited background, but there it can be significant, like 40% chance of getting ovarian cancer for patients, mutation in the BRCA1 gene. There we have identified 2 genes. And if you hear about breast cancer, you'll hear quite a bit more about it. Those are very big genes which are sequenced, and it's very interesting. We know where mutation can come, and especially in the Ashkenazi Jewish population, which lived in a very restricted area in Eastern Europe. You can find certain founder mutation. So basically where the patient's family was coming from. Because they intermarried a lot, they all have the same kind of mutation. People with Lynch syndrome have a slightly increased risk of familial ovarian cancer, probably. Okay, excuse me. Let's just shut it off. Familial ovarian cancer have an increased risk, but this is just the beginning of the tip of the iceberg. I think in the future we'll identify more and more factors. So, prevention of ovarian cancer will reduce the risk of ovulation. And here again, being pregnant all the time reduces the risk of ovulation. Again, most people prefer birth control pills. Very effective, again, reduces it for about 40%. And that is true for the general population. That is true for patients with the familial risk factors. That is also true for patients who have a mutation in the BRCA gene. So if they take birth control pills, their risk of ovarian cancer is significantly reduced. Now, the risk of breast cancer may be slightly increased, so it always needs to be a very individual decision. Breastfeeding may also have the same effect, because usually if you breastfeed, you don't ovulate, you don't release an egg. Now, more recently, with what we learned about the fallopian tube, reduce the tissue transfer. So instead of tying the tubes, you may just want to take them out, because the tubes don't produce any hormones. You know, they're just the way to get the egg to the sperm and to the uterus. So if you don't want to get pregnant anymore, just remove the tubes. And that is also under investigation for very young people with the genetic risk factors. Adequately treat endometriosis. We also do know, though, that hysterectomy and just tubal ligation reduces the risk of ovarian cancer. That may be related to the fact that outside factors or chronic inflammatory changes are not allowed in, basically. So again, the fallopian tube seems to be very important for the development of ovarian cancer. We also have now identified precancerous changes in the fallopian tube. The risk we didn't know about that before is because we did not remove that many normal fallopian tubes, because we weren't worried about it, you know. A contrast to the pap smear, where we look at the area right away and it's easy to get a sample. Now, I'm not advocating removal of everyone's ovaries just to prevent the risk of ovarian cancer. That is really not the recommendation, unless you are part of a high-risk family. I mean, when I started my training, over 45 we would remove the ovaries, and even over 40 we would think about it. Studies, though, have shown that most of these patients do not continue hormone replacement therapy, and then they get into big problem regarding heart and blood vessel health and regarding bone health. And again, overall, the risk of ovarian cancer is not that high. I mean, if you want to do surgery to reduce your risk of cancer, I think number one would be to have both breast removed, because that risk of breast cancer is so much higher. And number two would be to have the colon removed, because that risk is much higher. But no one would ever think of doing something like that. You know, and again, the same I think is true for the ovaries. We learn more and more the importance of the ovary as an endocrine organ, even around the time of change of life and shortly thereafter. And therefore, routine removal at time of hysterectomy has never ever been shown to improve overall survival. However, if you do it in women below age 40, you decrease overall survival just because of all those other health problems. I think to know your family history is important. So you can talk to your care provider about consultation with a geneticist to see if testing for the BRCA gene or other gene is important. So any first and second degree relatives with breast or ovarian cancer. People who get cancer on a genetic basis usually get it earlier in life. So any of your relatives with breast cancer at age in the 20s or 30s, or a woman with bilateral breast cancer, or men with breast cancer. So those are all a very important risk factor. And then discussion with a geneticist, I think, is important to assess your risk factor and then decide if you want to have the genetic testing, which would be important because if it gives you the option to do something about it. More frequent mammograms, MRIs of the breast, or even removal of the breast with reconstruction. More frequent pelvic exams, blood studies, ultrasound, or removal of the fallopian tube, or sometimes even removal of the ovaries. So, take-home message. Monitor your menstrual cycle, evaluate any kind of irregular postmenopausal bleeding, and take birth control pills. Also, I think, know your body. You know, if the early signs of ovarian cancer can be quite subtle. You know, you have just a little bit of dyspepsia, decreased appetite, early satiety, a little bit of bloating or uncomfortable feeling. We probably all have these symptoms at one time or other during the month. Just if you have them every day, and if they get worse every day, that's when you need to talk to your doctor. And there are easy tests to do in this situation. Not screening tests, but easy tests to find out if something abnormal is going on. And of course, keep a healthy lifestyle, all the non-smoking, normal weight. And again, not everyone needs to be yardstick thin. You know, we're just talking about big time overweight, morbid obesity, and things like that. Of course, if it's always a gradual situation. Exercise is important, and warning signs. Again, any kind of irregular uterine bleeding. Constant new onset, constant pain needs to be evaluated. But pain probably would be a good thing because everyone hates pain, and so they go to see someone. Whereas sometimes the early signs of ovarian cancer are so subtle that people tend to just forget about it. Therefore, change of bowel and bladder function or persistent indigestion.